This is a video in clinical medicine from the New England Journal of Medicine.
Radial arterial puncture for arterial blood gas analysis is a common procedure performed in medicine. It is a fundamental skill that all medical trainees need to acquire. This video will review radial arterial puncture in the adult population. Puncture of the radial artery is the preferred method of obtaining an arterial blood sample for blood gas analysis. The chief indication for measurement of arterial blood gas level is to obtain values for the partial pressures of oxygen and carbon dioxide, and for arterial pH. This information is needed when assessing a patient with acute severe respiratory distress. Measurements of arterial pH and the partial pressures of carbon dioxide and oxygen provide accurate information on the status of acid-base balance and gas exchange. Another indication for arterial blood gas analysis is co-oximetry in order to assess for methemoglobinemia and carboxyhemoglobin. Radial arterial puncture is contraindicated in the presence of a known deficiency of collateral circulation to the distal upper extremity. Some physicians advocate for the use of the modified Allen test to assess the adequacy of collateral circulation of the radial artery by the ulnar artery. The Allen test is controversial, however, in that its ability to predict the risk of rare ischemic complications accurately is limited. Thus, based on current evidence, its use can be neither refuted nor supported. To perform the Allen test, occlude both the ulnar and radial arteries. Instruct the patient to make a fist to drain the blood from the hand. This should be done for approximately 30 seconds. Instruct the patient to unclench the fist. The patient's palm should appear blanched or pale. Now release pressure only from the ulnar artery. Adequate collateral circulation is indicated by the return of normal color within 10 seconds. Alternative techniques that can be used to measure collateral circulation of the forearm include color Doppler flow study, plethysmography, and MRI. These methods are more often used when assessing the radial artery for more invasive procedures, such as arterial harvesting for coronary bypass. In addition, radial arterial puncture should not be performed in the presence of an overlying skin infection. It is relatively contraindicated in patients receiving anticoagulants or in those with coagulopathies because of the increased risk of bleeding and hematoma formation. Standard arterial blood gas sampling kits are readily available that contain a syringe, a small 23 to 25 gauge needle either with a rubber stopper that may be used to remove the needle from the syringe or with an attached safety cap, and a syringe cap containing dry lithium heparin or sodium heparin. The concentration of heparin here varies depending on the manufacturer of the kit. You will also need the following: alcohol swabs, sterile pieces of gauze, tape, non-sterile gloves and a non-sterile gown, 1% lidocaine without epinephrine for local analgesia, a 5 cc syringe with a 25 gauge needle, a small rolled towel to place under the wrist, and a bag of ice in which to transport the sample to the lab if required. Arterial blood gas sampling often takes place in an emergency setting and may not allow for obtaining consent from the patient or next of kin. When possible, the procedure should be explained to the patient and consent obtained. Wash your hands according to good standards prior to examining the patient. Extend the patient's wrist to bring the radial artery close to a more superficial position. The radial artery is located between the styloid process of the radius and the flexor carpi radialis tendon. First, palpate the styloid process of the radius. Next, palpate the flexor carpi radialis tendon located medial to the styloid process of the radius. Now locate the artery between these 2 points. The artery may be difficult to palpate, for example, in the presence of overlying edema or vasospasm. A portable Doppler ultrasound device may be used to identify the location of the radial artery in these instances. Extend the patient's wrist and place a rolled towel under it to maintain it in an extended position. Once the patient's wrist is positioned, put on a non-sterile gown and non-sterile gloves. Open the arterial blood gas kit and identify all the components so they are ready for use. Clean the site with an alcohol swab. Palpate the radial pulse and determine the point of maximum impulse, or use the Doppler ultrasound device to identify the location of the radial artery. Using the 5 cc syringe and small needle, draw up 1% lidocaine. Upon introducing the needle under the skin, draw back on the plunger to ensure that you have not punctured a vessel. Inject a small wheel of analgesic around the artery and wait 30 to 60 seconds for the lidocaine to take effect. Again, locate the maximum impulse with the index and middle fingers of the non-dominant hand. Holding the arterial blood gas syringe with the dominant hand, aim the needle away from the hand and toward the upper arm, and puncture the skin at a 30 to 45 degree angle at a point just below the index and middle fingers of the non-dominant hand. Advance the needle slowly until the syringe easily and passively fills with bright red pulsating blood. Ideally, you should obtain at least 1 to 2 cc's of blood. If no blood is obtained, do not pull back on the plunger. Withdraw the needle slowly until it is just under the skin and reattempt the procedure. After the blood sample is collected, withdraw the syringe and have an assistant apply pressure to the site with sterile gauze for approximately 5 minutes. In the meantime, expel the air bubbles from the syringe. Cover the needle with the attached safety cap and remove the needle from the syringe, or remove the needle from the syringe using the rubber stopper. Attach the heparin-containing cap and, while holding the cap in place, push the plunger of the syringe to ensure the blood encounters the heparin. This will prevent the blood from clotting. Ensure that the syringe is labeled with the patient's name and unit number. Place the entire syringe in the bag of ice if transport to the lab is required. After pressure has been applied to the puncture site for 5 minutes, affix the gauze with some tape. Dispose of all sharps in the designated sharps containers. The most common technical difficulty associated with radial arterial puncture for arterial blood gas analysis is failure to obtain a blood sample because of vasospasm, or obtaining venous instead of arterial blood. If vasospasm is suspected, abort the procedure and reattempt it on the other wrist. A blood sample is likely to be venous if it is non-pulsatile and dark in color and it flows slowly. It should be noted, however, that very deoxygenated blood in a patient with hypoxemia could also appear dark, even though it is arterial. Serious vascular complications of radial arterial puncture are rare and include radial arterial aneurysm, hand ischemia, and hematoma causing compartment syndrome. Arterial blood gas analysis provides useful information regarding respiratory and metabolic pathology. The partial pressure of carbon dioxide, bicarbonate concentrations, and pH values will assist in diagnosing the presence of primary or mixed respiratory and metabolic acidoses or alkaloses. The partial pressure of oxygen will reveal abnormalities in blood oxygen content and the presence of hypoxemia. With the appropriate technique, radial arterial puncture for arterial blood gas analysis is a skill easily mastered by medical trainees. A more detailed approach to acid-base disorders and hypoxemic respiratory failure, while necessary, is beyond the scope of this instructional video.
One of the ways we evaluate newborns as far as blood gases is concerned is called the capillary blood gas. This differs a little bit from the arterial blood gas, and that the values are different, the technique's different, and obviously size on the newborn is a complication there, where a lot of our needles are larger than their arteries. So if we went to stick them with a 22 gauge needle, we're liable to sever their artery. So many times in the nursery we resort to the capillary blood gas. The capillary sample can accurately reflect and provide clinical useful estimates for pH and CO2 levels. The capillary PO2 is of no value in estimating oxygenation, so that's done by the saturation. The most common technical error in capillary samplings are inadequate warming and squeezing of the puncture site. Squeezing the puncture site may result in venous and lymphatic contamination of the sample.
This video is about capillary blood sampling in the newborn. Capillary blood sampling is the most common and preferred route to obtain blood in the newborn period. Capillary heel sampling, more specifically, is an easily mastered, minimally invasive technique that provides laboratory data similar to venous and arterial samples. Capillary heel sampling preserves those precious veins and arteries for future reference if intravenous or intra-arterial access is required. Limitations of capillary blood sampling are encountered when blood cultures are required, coagulation studies are required, the volume of blood exceeds 1.5 mLs, or when minimal amounts of hemolysis will alter the validity of the laboratory value being assessed. The equipment required for capillary blood sampling is as follows. A heel warmer is utilized to promote vasodilatation and increase the blood supply to the region. Chloroprep, betadine, or alcohol swabs are typically used to cleanse the area prior to lancing the heel. The agent utilized will depend upon the institutional guidelines. Appropriate blood collection microtainers or capillary blood tubing. A piece of gauze is used to wipe away the initial drop of blood and to tamponade the hemorrhage when the sampling is complete. A pacifier and sucrose solution for pain control measures. An automated heel lancet. The type of lancet is selected based upon the size of the infant and the subcutaneous tissue that must be penetrated. The micropreemie tenderfoot lancet is used for those infants less than 1,000 grams. The preemie tenderfoot lancet is used for those infants greater than 1,000 grams. The newborn tenderfoot lancet is typically used for those infants that are term through the first 6 months of life. Each lancet varies in the length and depth of the incision created. The infant's identity was assessed by utilizing 2 of the approved JACO identifiers, and the blood sampling necessity was confirmed with the medical provider. A heel warmer was in position for 5 minutes, and oral sucrose was administered for 2 minutes prior to initiating this video recording. A heel warmer is being utilized for visual confirmation of the appropriate application. The preferred area for capillary sampling is the outer aspect of the heel. Do not use the end of the heel. The calcaneum is superficial at this site, and there is an increased risk for the development of osteomyelitis. An alcohol swab is being utilized to cleanse the future puncture site and the surrounding tissue. The appropriately sized tenderfoot lancet is being used to puncture the heel. The first drop of blood is wiped away with a piece of gauze. Subsequent blood will be collected for sampling. Please note that the infant is swaddled and additional sucrose is administered intermittently for continuous pain control. Notice the hand positioning. The fingers are along the calf and the thumb stabilizes the ball of the foot. Pressure is applied to the calf in a direction towards the heel. Free-flowing blood is collected in a microtainer. When the blood flow ceases, calf pressure is released, the capillaries are allowed to refill, and the process is repeated. Do not squeeze the heel. Squeezing the heel results in greater pain, lower blood yield, and increased cell lysis. If the bleeding stops, wipe the site with gauze to disrupt the clot formation. If the blood still does not flow freely, choose another site and repeat the procedure. Be certain not to scrape the heel with the microtainer. This will cause hemolysis and lead to inaccurate lab results. Once again, pressure is applied to the calf in a direction towards the heel. Free-flowing blood is collected in the microtainer. When that blood flow ceases, calf pressure is released, the capillaries are allowed to refill, and the process is repeated. When the capillary sampling is complete, tamponade the puncture site and wrap with gauze or an adhesive bandage.
So once we have the blood collected, we're going to run it through an analyzer. And so what these blood gas analyzers do is they measure the pH, the PaCO2, and the PaO2. Several secondary values are calculated. For example, the plasma, the bicarbonate, the base excess, and the hemoglobin saturation. Some analyzers may combine the blood gas and the hemoximetry measurements all in the same cabinet, and so you get the readings all from one sample. You just need to know your equipment. That's not necessarily the case all the time. There can be several different types of instruments that measure the pH, the CO2, and the PO2. It can be electrochemical electrodes like we talked about previously, like the Clark electrode, optical fluorescence, and photoluminescence. And of course the NBRC doesn't like to say the PO2 electrode or the oxygen electrode. They'll call it the Clark polarographic electrode. The CO2 electrode is referred to as the Servinghouse electrode. And the pH is just the pH electrode typically, but it usually consists of two different electrodes or half cells. One of them is a measuring electrode and the other is a reference electrode. So then how is the bicarb measured? Well, the bicarb is not measured. It is calculated using the Henderson-Hasselbalch equation. It is one of the unknowns. You put in all the other unknowns and you can calculate the bicarbonate. Here's an example of a pH electrode system. This is figure 18-6 on page 394. You see it has a reference electrode or reference half cell and a measuring electrode. And notice that it has an electrolyte solution in it. So occasionally you have to resupply that electrolyte solution. So how is it then that we trust the values that the blood gas machine gives us? Well, this is because of the quality assurance that's required in maintaining the blood gas equipment, what they refer to as rigorous quality control efforts. The components of the quality control are record keeping, and this is in the policies and procedures, and in fact the lab regulating agencies through the government are going to require record keeping. Performance validation, testing of new equipment or new instruments, and comparing them to the old instruments and their results. Preventive maintenance and function checks, automated calibration and verification, internal statistical quality control. So this is where you do 2-point cals or 1-point cal. 1-point calibration is done after every sample. A 1-point calibration is measured against a known substance, whether it's a liquid or a gas, where you program in to the machine what the value is, and then you compare the measured value, and it has to be relatively close in a certain percentage, or the machine goes into default and you have to do maintenance on it. External quality control, this is also called proficiency testing. This is where you have to subscribe to an external service that will send you unknown values. So every 6 months or so, you have to call these people up and say, okay, we're ready to test this, and they'll send you some vials without labels that has artificial blood in it. And so you run these samples through your machine, you print out the results, and you send those results back to your service. And then they tell you how close they were. And so that's just external quality control. And then remedial actions, anything you would do to correct errors, whether you're changing the electrodes, you're replacing the electrolyte solution, or you're running a 2-point cal, whatever you're doing, you have to document that. So QC components, the record keeping is obviously of vital importance, simply because it can be a legal document also. You know, if a case goes to court and you provide values to the jury, well, first thing they're going to ask is, how do we know these are accurate? And then you're going to have to produce all the quality control stuff that says, yeah, the machine was performing to its capability. Preventive maintenance and function checks, the automated calibration. And this automated calibration, this is pretty much commonplace today, where we used to have to do it manually a couple times a shift. But now you can buy automated calibration media where the machine does this automatically, and you don't have to be standing there by the machine and actually program it in. And of course it records it every time it does a calibration. Now, the thing about the automated calibration is, if for some reason something goes wrong and it doesn't reach that calibration, or if it can't calibrate, then your machine goes down, and then you have to do more maintenance on it. So those automated calibrations also include verification by control media. In other words, that's me standing in front of the machine, putting this control media in there that I know what the values are. This is artificial blood again, but I know what the values are this time, and I'm comparing the analyzed results to what I read on the package, what the package tells me is in there. And then of course the quality control, the external quality control, like I stated previously, this is that service that sends you the media without the values on it. And then the remedial actions, what are you doing about errors, things like that. A 2-point calibration is actually done every few hours in regular intervals, whether it's every 4 hours, every 6 hours. But there's 2 points of calibration now, and typically a high oxygen level, a low oxygen level, a high CO2, a low CO2, a high pH, low pH. And so that's what they talk about when they talk about a 2-point calibration. And so this kind of fine tunes the instrument in that it gives it a wider range of accuracy. And so usually when after you do maintenance on the equipment, then you'll run it through a 2-point cal and make sure it's operating efficiently.